So in the first section, we discussed about the gastrinoma, which is the pancreatic neuroendocrine tumor that produce excess gastrin and cause excess gastric acid hypersecretion. Now in this section, we will discuss two other pancreatic neuroendocrine tumors, which are the insulinomas and glucagonomas, related to the two hormones produced by pancreas, insulin and glucagon. So these are the insulinomas and glucagonomas. So we will discuss about the what are these, and then what are the clinical features of these two conditions, and how we can diagnose and treat insulinomas and glucagonomas. Insulinomas is a neuroendocrine tumor of pancreas that is thought to be derived from beta cells of the pancreas that secrete insulin, which result in hypoglycemia. So insulin is the hormone that is produced by the pancreas, and this insulin is responsible for the glucose metabolism. If the insulin is more, this causes decrease in the level of the glucose and cause hypoglycemia. Patients who have diabetes, they do not have enough insulin, so their blood glucose level rises in the body. So insulin is the hormone responsible for the metabolism of the blood glucose. So insulinomas is the tumor or neuroendocrine tumor that produce more insulin in the body, leading to hypoglycemia. That's the picture showing the insulinomas in the pancreas, beta cells of the pancreas. They are small. 5 to 15% of insulinomas are malignant. The rate is much higher. If you remember, we said gastrinomas are more higher rate of malignancy as compared to this insulinoma, which is only 5 to 15% are malignant. They are small, not big. Equal distribution in pancreatic head, tail and body. The pancreas is made up of three parts. We have the head, body and the tail. So insulinomas are equally distributed. It's not that it mainly develops in the head or body or the tail. Equal ratio or percentage is present in all the three parts of the pancreas. Suspected in hypoglycemic patients. Patients who have attacks of hypoglycemia and there is a high level of insulins, suspect that these patients might have insulinomas. Family history of MEN1, multiple endocrine neoplasia 1 is usually present in these patients. Elevated insulin, C-peptides, plasma, pro-insulin levels are present in the patient with insulinomas. Clinical features, usually all the features associated with hypoglycemia. Our brain is the main source of energy for the brain is the glucose. Our brain gets energy from the glucose. So whenever there is hypoglycemia, all the features are associated with that. There is dizziness, weakness, shakiness, all that. So features are mainly due to hypoglycemic state. Neuroglycemic symptoms. Confusion, headache, very common. Disorientation, visual difficulties, coma, irrational behavior, excess catecholamine, and sweating, tremor, palpitations. All these are associated with decreased level of glucose. Patient even can go into coma, hypoglycemic shock when their blood glucose level is very low. They need to get the glucose immediately glucose infusions are given to bring the glucose level high so they can feel better. So dizziness, drowsiness, headache, disorientation, they are all very common in patients who have insulinomas and hypoglycemia. Diagnosis is by the very important demonstration of insulin level. If they are high, think about insulinomas. Postprandial hypoglycemia confused with diagnosis. So postprandial hypoglycemia, after the meal hypoglycemia, usually it confuses with the diagnosis, and usually we think that it might be due to the break between the eating or after. So that's the can confuse with the diagnosis of insulinoma. A reliable test is fast up to 72 hours. Measurement of sulfonylurea levels, radioimmunoassays. So all these are different diagnostic tests for insulinomas. Assessment of proinsulin and C-peptide levels. Treatment of insulinomas, we have surgery, laparoscopic approach to remove the insulinoma, diazoxide intake, other agents like verapamil, diphenylhydantoin, somatostatin analog like octreotide, rapamycin mTOR inhibitor, anti-tumor treatment, hepatic arterial embolization, chemoembolization, chemotherapy. All these are different treatment options for the insulinomas. And remember, the complications can occur as a result of very low blood glucose level that let the patient can go into the shock or coma. And peptide receptor radiotherapy. So different treatment options: surgery, diazoxide, verapamil, diphenylhydantoin, somatostatin analog like octreotide, anti-tumor treatment, hepatic arterial embolization, chemoembolization, chemotherapy, and peptide receptor radiotherapy. Now the other condition is glucagonomas. A glucagonoma is again neuroendocrine tumor of pancreas that secrete excess glucagon. Two hormones, insulin and glucagon, produced by the pancreas. Insulinomas causes increased insulin, decreased level of glucose. Glucagonomas cause increased glucose, so which causes distinct syndromes characterized by dermatitis, glucose intolerance or diabetes, and weight loss. So we saw insulin was decreasing blood glucose level. Glucagon has opposite effect. It increased blood glucose level and it can cause diabetes, in which patient has high blood glucose level, and it also causes dermatitis and weight loss. Large at diagnosis, they are not small tumor, and they are 50 to 80% in the tail of the pancreas. For insulinomas, we mentioned that they are mostly equally distributed in the head, tail, and body, but glucagonomas are mostly in the tail. Rarely extrapancreatic, they are usually single. Glucagon cell adenomatosis and Mahava disease mimic this condition. So rarely extrapancreatic single, they are two conditions which closely mimic this is glucagon cell adenomatosis and Mahava disease mimic this condition. Then the clinical features of glucagonoma, we have characteristic dermatitis. You can see the dermatitis of glucagonoma, glucose intolerance, weight loss, thromboembolism, diarrhea, anemia, annular erythema in the ring shape, annular, lesions formation and hypoaminoacidemia. So all these are the features of glucagonoma. Diagnosis is by the measuring the glucagon level which are increased in glucagonomas. Lower level at diagnosis, some conditions show elevated glucagon levels like pancreatitis also, and there is necrotic migratory erythema which is not pathognomonic of this condition, not confirm this condition, but there is necrotic migratory erythema present which is not pathognomonic. So all these are the different tests for the diagnosis. Treatment of glucagonoma is no surgical resection. Surgical debulking is done to decrease the size of the tumor and debulk the tumor. Anti-tumor treatments and somatostatin analogs, all these are different treatment options for the glucagonoma. So that was all about section 2, in which we discussed in detail about 2 neuroendocrine tumors of the pancreas, insulinomas and glucagonomas. Thank you for watching sqadia.com.